Hello, everyone, and welcome to the third Native Chart webinar in our webinar series. My name is Crystal Poop, and I am the Community Health Outreach Coordinator and Tribal Liaison for Partnerships for Native Health. Our agenda today will have a brief welcome and a brief discussion of iReach and Partnerships for Native Health and a little bit more about Native Chart. And then I will pass it on to our main speaker, Dr. Sinclair, and she will talk about the ENACTS program. And engaging Native Hawaiians and Pacific Islanders and activating communities to take steps. And then at the end, we'll have the question and answer time. So Native Chart and Partnerships for Native Health is under the larger research center called the Initiative for Research and Education to Advance Community Health, or iReach. It's at Washington State University. And we challenge the status quo and advance community health through partnership and collaboration. The vision of Partnerships for Native Health is diverse American Indian and Alaska Native constituents and academic partners working together in real-world settings to improve health through research, education, and technical assistance, and by focusing on community strengths. Some research topics include alcohol use disorders, substance use disorders, smoking and nicotine dependence, suicide prevention, mental and behavioral health, cognitive impairment and Alzheimer's disease, high blood pressure, diabetes, and stroke risk reduction, to name a few. Native Chart, our Native Controlling Hypertension and Risk Through Technology, is a research center that aims to improve control of blood pressure and other risk factors for cardiovascular disease in American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders with diagnosed hypertension. It comprises 3 community-based intervention projects and 4 supporting cores. Our partners include the Chickasaw Nation, South Central Foundation, Oklahoma State University, and Colorado School of Public Health. And the research is supported by the National Institute on Minority Health and Health Disparities of the National Institutes of Health under award number U54 MD011240. Native Chart is comprised of multiple satellite centers, one in Seattle, Washington, one in Denver, one in Tulsa, Oklahoma, one in Minneapolis, Minnesota, Albuquerque, New Mexico, North Carolina, and Anchorage. And now I'd like to introduce Dr. Kaimi Sinclair to talk more about the ENACTS program within Native Chart.
All right, well, good morning, everybody. Thank you so much for joining us. My name is Kaimi Sinclair. I am an assistant professor here at iReach in Washington State University, and also I'm an assistant professor in the College of Nursing as well. Welcome today to our Engaging Native Hawaiians and Pacific Islanders and Activating Communities to Take Steps to specifically control high blood pressure. So let me get started. So first, I'm going to talk a little bit about the significance and background of our work. So Native Hawaiians and Pacific Islanders have ancestral origins in any of the original peoples of Hawaii, Guam, Samoa, and other Pacific Islands. About 1.2 million, or 5% of the US population, are Native Hawaiian or Pacific Islander. In 2011, Native Hawaiians were the largest NHPI group, 43%, followed by Samoans, 15%, and Guamanians or Chamorros at 9%. The NHPI population grew 4 times faster than the all races population from 2000 to 2010. And NHPIs are projected to number more than 2.6 million people by the year 2050. So here we have Western Washington. So approximately 70,000 NHPIs live in Washington state, constituting about 1% of the population. NHPIs in Washington experience significant socioeconomic disparities. For example, in 2014, high school graduation rates for the 4-year cohort were 54% to 65% for Pacific Islanders versus 77% overall. In Washington, 1 in 7 NHPI households has an income below the federal poverty level. And compared to the state's all races population, per capita income is substantially lower at $18,225 versus $33,139. So prior to Western contact, Native Hawaiians and Pacific Islanders had an enviable health status. A high prevalence of chronic diseases in Native Hawaiians and other Aboriginal populations is in large part a result of colonization and cultural hegemony that altered traditional practices, access to healthy food sources, and the roles of men and women. Native Hawaiians and Pacific Islanders suffer a disproportionate burden of hypertension, diabetes, cardiovascular disease, and stroke compared to other racial ethnic minorities, as well as to all races population. NHPIs are 3 to 4 times more likely to have coronary heart disease and stroke than whites, and they experience these conditions an average of 10 years earlier. The rates of mortality for coronary heart disease and stroke are 68% and 20% higher, respectively, than in the all races population. And NHPIs are 30% less likely to have their blood pressure under control. But we know there are things that we can do to control blood pressure and reduce the risk of heart disease. So now I'm going to talk about the specific aims of our study. And there are 3. So at the individual level, our aim is to compare within-person change in blood pressure and secondary outcomes between the intervention and control groups. We use a waitlist control group, though. And our hypothesis is we expect more improvement in the intervention participants. At the family level, to evaluate ENACTS' effect on blood pressure and secondary outcomes as within-person change in family members who provide primary support, and as a mean change in other adult family members who aren't directly engaged in the intervention. And we expect more improvement associated with those involved in ENACTS. And then our third aim at the policy level is to evaluate the intervention's ability to influence grocery store policy on using labels to clearly identify foods that are low in sodium and high in potassium, some of which might not be easily identified with existing labels, such as fresh produce and prepackaged foods. So we expect ENACTS to promote adoption of such policies. And we'll talk more about how we expect that to happen. But first, our team, let me introduce our team who all could not be here today. We have Keawe Kaholokula from Hawaii. He is our NHPI health expert, and he's a psychologist by training. We have Edmund Sito from the University of Washington, and he created an app for our participants to use, which I'll describe later in the talk. We have Katie Nelson, one of our research coordinators. And we have Nicole Lee Ellison, seen on the far right in the first picture on the left, and then Dan Pritchard, who is our peer educator. And we have another research coordinator, Cassiera Cruz, you'll see on the right. We have several recruitment sites. Our first is Asian Counseling and Referral Services, the Asia Pacific Cultural Center located in Tacoma. And we have many sites in Western Washington that we are recruiting from, churches and other activity sites. And there's a site in Spokane that we're starting to work with. There's a large Marshallese population in Spokane, so on the eastern side of the state. So now I'm going to talk about our approach that we're using in our intervention. So this is a picture of our theoretical model. We expect that, well, the model reflects a mutually reinforcing relationship between the individual and family levels, which we hypothesize leads to improved blood pressure control through a pathway that's mediated by motivation, self-efficacy, and transformation of the family environment, and then healthy eating. So our individual level intervention comprises an educational intervention with 8 weekly sessions on blood pressure management and cardiovascular disease prevention. Our education emphasizes dietary change, including elements of the low sodium dietary approaches to stop hypertension, or the DASH diet some of you may have heard of, and other lifestyle changes to improve blood pressure, such as physical activity and medication adherence. So after the last educational session, participants receive regular text messages during a 4-month maintenance phase to maintain or further improve their blood pressure control. Then at the family level, we have a single family member enrolled in the project with each participant who acts as a primary support person and is trained to provide autonomy support, which is a skill set that emphasizes supporting self-efficacy and healthy behaviors in others while honoring their autonomy to set priorities and make choices. And then at the policy level, we have an intervention that enhances the individual and family impact by strengthening real and perceived support for better health and blood pressure management. After completing the 8-week curriculum, participants engage in a photo voice project to persuade grocery stores to clearly identify pre-made foods and fresh produce that might help lower blood pressure. And I'll talk more about the photo voice in a few minutes. Our eligibility criteria for participants include a self-reported physician diagnosis of hypertension, which is confirmed by hypertension medications, or a systolic blood pressure of 130 or higher on 2 separate occasions. So individuals don't have to have a physician diagnosis of hypertension. Self-reported Native Hawaiian or Pacific Islander, 18 years of age or older, the baseline systolic blood pressure of 130 or higher, possession of a cell phone with text messaging capability, not living in a household with a participant who's already enrolled in the study, ability to understand written and spoken English, and the ability and willingness to follow all study protocols. The support person that each participant enrolls in the study with them has to be 18 years of age or older, also possess a cell phone with text messaging capability, understand written and spoken English, and a willingness to follow the study protocol. These are pretty standard criteria for studies. This is just a picture of our study flow diagram. So we are planning to screen and enroll 270 participants, and each of those participants will have a support person that joins the study with them. We collect the baseline data, and then we randomize people. So randomizing, for those of you that might not be familiar, is kind of like flipping a coin. And some people are going to be assigned to the program right now, and others will get the program a little bit later. But this way we can see if the program actually works or not. So it's just a part of our study design to see if it really does work. So we have people that are randomized to the intervention group that get the program right away, and then people that are in the waitlist group who will get the program later, the education. So after they're randomized, the intervention group receives the 8 weeks of education, and at the end of each class, they order $30 worth of groceries. The people in the waitlist group also get to order the $30 worth of groceries each week. At the end of the 8 weeks, we collect data again on both groups, and then the maintenance phase starts for the intervention group. We do a 3-week photo voice project with the intervention group, and then we have 16 weeks total of text messaging, and then there's a 6-month data collection. And then after the 6-month data collection, then the waitlist group receives the same education. So everybody's going to receive the education and the grocery ordering, just at different times. These are just a list of our data collection, our measures, and some of the outcomes. So we collect data on participants at baseline, at 8 weeks, and then at 6 months. We're measuring sociodemographic questions like age, sex, and then we have diet questions, lots of diet questions, physical activity, height, weight, smoking status, alcohol consumption, and comorbid conditions, such as do people have diabetes or other conditions that may play a part in their blood pressure. Our primary outcome, of course, is blood pressure. We're also examining medications, dietary behaviors, food purchasing. So every time people order food, the $30 worth of groceries each week for 8 weeks, we have the receipt from those grocery orders, and we can compare what the foods are that the intervention group are purchasing compared to those for the waitlist group. We have the CalFit, which is also called BiteSome, which is the app that I'm going to talk about that Edmund Cito developed, which can track steps and energy expenditure. And then the autonomy support for the support person, and then of course knowledge. And we do a process evaluation as well to assess participant satisfaction, exposure, so how many classes did people go to, and reasons for dropout. Our baseline visit is quite lengthy. It takes, for the participant, there are 2 baseline visits. So of course we have the informed consent process. There are study forms to be filled out, like people's address and phone number so we can reach them. We have a dietary history questionnaire, a 3-day food diary. We're collecting 24-hour urines because that's the most objective way to measure dietary sodium and potassium consumption. And multiple blood pressure measurements and height and weight. And then after that first visit, they come back a week later and we administer the study survey, which asks those questions about alcohol, smoking, and other conditions that they have. And there's another survey called an ASA 24, which is another 24-hour dietary survey. We have the support person also complete the informed consent, the study forms, the same dietary history questionnaire, the 3-day food diary, multiple blood pressure measurements, and the study survey. So now I'm going to talk about our curriculum that we developed for the educational component for the individuals. We call it Healthy Hearts Among Pacific Islanders, or HAPPY. So the goal of the HAPPY education is to increase knowledge and skills to manage blood pressure and to promote the HAPPY eating plan, which, as I mentioned earlier, is adapted from the dietary approaches to stop hypertension, or the DASH eating plan. The eating plan encourages whole grains, fish, poultry, beans, seeds, nuts, and healthy fats and oils. It limits sodium or salt intake, sweets, sugary drinks, and red meats, and encourages vegetables, fruits, and fat-free or low-fat dairy products. So during the educational classes, participants are encouraged to bring their support person that they do not have to attend. Curriculum materials emphasize the American Heart Association guidelines, and we use social cognitive theory, which is a behavior change framework, and we combine that with theoretical constructs. We combine the theoretical constructs with cultural symbols and themes, cultural patterns and concepts, values, norms, and relationships to promote blood pressure control and behaviors such as healthy eating, exercise, medication adherence, and stress-reducing activities. So the culturally congruent content was developed and builds on ethnic group identity and social support to promote self-management behaviors. So sociocultural strategies that are that position hypertension in the context of participants' cultural values and characteristics are incorporated into the intervention to enhance its salience. So for example, to reinforce the tradition of families and communities working together, each of the classes begins with a story that depicts a local character and their daily challenges and strategies they use to manage blood pressure. So our first intervention group was all Samoan. And so the characters in the story are Uncle Fatu and Kimo. And our peer educator, Dan Pritchard, is Samoan, and he delivered the classes for this group, and he helped us come up with the names and make the stories culturally relevant and tailored for these groups. So as we deliver the program to other Pacific Islander groups, we will change the names in the story and make sure that they're relevant to each group. This is just a picture of the format of our curriculum. So every page is laid out in this way. This is the page, the first page of the first meeting. So we have our logo at the top and the titles on the side or pictures, and then the content on the right side. And this slide shows the title of each of our 8 meetings. So we talk about keeping your heart healthy, things that can happen if we don't keep our blood pressure under control. In the second meeting, we talk about your healthy heart team. So who are the people that you need to help you manage your blood pressure? And while that second class is going on, there's a concurrent class going on with the support person that teaches them how to provide autonomous support. And I'll describe that more in a minute. Our third and fourth meetings focus specifically on heart healthy foods. But in each meeting, we do talk about a part of the happy eating plan. But meetings 3 and 4 focus only on these foods. Our fifth meeting focuses on physical activity, so sit less and move more. The sixth meeting, we talk about medicine and their benefit to blood pressure balance. The seventh meeting, we talk about managing stress through stress-reducing activities and exercises, and we do a lot of role-playing and activities to practice those things. And then finally, the eighth meeting is about be the change. So be a role model for your family and your community, and continue to maintain these healthy behaviors to avoid complications. So the support person, as I mentioned, it goes through, they have one class that's specifically just for them, that happens at the same time as the second class for the participant, focused on autonomy support. So that's when a support person respects the other person's views or attitudes and offers choices and encourages the person to make a decision. So in that meeting, we talk about their role as a partner in health, how to show empathy and concern rather than scolding or criticizing someone, how to offer choices. We do problem solving and role playing in that class. And we encourage, as I mentioned, the encouraging rather than criticizing, and we set goals. So in each of the participant classes, we also have participants set goals for something related to blood pressure control. This is a picture of some of the pages in the Bitesome app that Edmundcito developed for us. And we've only had one cohort of participants so far. And that group of participants, it was an older Samoan group. English was not many of their first language, so we haven't had anybody use this app yet. They were not very familiar with taking pictures with their phones, and they did not want something, an app put onto their phone. So we've come up with a new, a new part of our education that will be devoted to this app to tell people more about it, rather than assuming people will just let us put an app on their phone at the beginning of the class or at the beginning of the study. Finally, our policy level intervention. So the overarching goal of Photo Voice is to generate grassroots advocacy for local grocery retail outlets to adopt policies that will assist in blood pressure management. So in Photo Voice, we have participants take photographs that represent community concerns, assets and barriers, and facilitators related to dietary practices and general hypertension management. The images are interpreted collectively, and the narratives are developed to communicate the information about hypertension as a public health problem and to inform policy change. At the end of the Photo Voice project, each group then presents their project as a group to owners or managers of local supermarkets, grocery stores, and convenience stores where the participants regularly shop for food. So we're hoping that some of the participants will really take this on and be the leader in their community to communicate with local grocers about better labeling foods so that they can keep their customers healthy and happy. In this last year, as I mentioned, we had our first cohort go through the study at the Asian Counseling and Referral Services, and it was an existing retired group of Samoans who met every Friday just to get together. There were many couples in the study, which actually worked out because one was eligible typically, and then the other person, their husband or wife or partner, was the support person. So they all got to participate. And we're enrolling new cohorts now, additional Samoan groups, Chamorro, Marshallese, and Micronesian groups around Western Washington and in Eastern Washington. So with this first cohort, we really got to test how long this study actually takes. Now, to recruit Native Hawaiian and Pacific Islander community groups, and I need to mention too that there are no other research studies that include Native Hawaiians and Pacific Islanders in Washington, even though we have the third largest population of Native Hawaiians and Pacific Islanders. So it takes some significant time to build these relationships and to recruit participants into research. So it can take anywhere from 1 to 3 months to get a group together for this study. So we recruit the individuals, we complete our 2 baseline data collection visits, which can take a month because they're quite lengthy. We have our intervention classes over 2 months, so 8 weeks. Our first follow-up data collection takes about 2 weeks to get everybody back through the data collection. And then our maintenance phase is 4 months. And then we have the final 6-month data collection, which takes about 2 weeks again to collect all that same data. And then the waitlist group will receive the classes over a 2-week period. So it's about 9.5 months per cohort. And when you have relatively small cohorts so that they can meet as a group and, get something out of it, it will take quite some time to get to 270 individuals, but we are working hard and we are hiring additional people for the Pacific Islander groups that will be appropriate to deliver those classes. Some of the lessons we've learned, as I mentioned, many of the Native Hawaiian Pacific Islanders here have had no prior experience participating in research. So it takes a significant amount of time for us to recruit groups, explain what research is and why we're doing the study the way that we're doing it, and to get buy-in to do it that way. The lengthy baseline data collection, as I mentioned, we have eliminated some of the original surveys that we had included in the survey, and then the follow-up data collection is a little bit shorter. There's also the heterogeneity of Pacific Islander community. Not all Pacific Islanders are the same, of course. There are many different kinds of Pacific Islanders, and they each have their own language, and we have to adapt to those different groups that we're working with and hire people from those communities that speak both English and can translate into their own language in order to reach enough people. We have new recruitment sites, Vancouver, Portland, Everett, and Spokane that we're working through. And many times it's better to capitalize on existing groups because it can be difficult for people to have to show up for classes, during a time when they don't normally get together. And we have, as I mentioned, the new strategy to explain the Bitesome app and to get participant buy-in so that we can load it onto their phone and collect information and teach them how to take pictures with their cell phone if they don't already know how to do that. And I think that's all I have. So we have plenty of time for questions. I look forward to it. Thank you. Oh, so you can raise your hand if you have a question or type it in the Q&A box. No, it's up here. Go there. So hold on one second. We're working on this. Ah, there it is. Where's the chat box? Is it under more? So click, go down. Oh, I see. Thank you. We're figuring this out. All right, we have a question. I'm working with Native Hawaiians, Pacific Islanders on research project in Bremerton, Puget Sound region. Our focus is on mental health and student-parent engagement in school. It's a very long, slow process. Yes, I agree. And we have to be prepared for that when we do community engaged work. It can be a very long process, and particularly when groups that we work with haven't ever engaged in this kind of work with academics or service providers before. So I appreciate it. I appreciate your comment, and I am with you all the way. And I think our funders need to, and many of them do, realize that this can take significant time to build these relationships and to get buy-in from communities. All right, this multi-level intervention, we have another chat here. Multi-level intervention is innovative and synergistic. For each of the levels, how did each particular strategy was decided upon, the support person strategy and photo voice? So these strategies, and for this particular funding opportunity, it had to be multi-level and have at least 3 levels of intervention. Not many researchers intervene at 3 or more levels of intervention because it's very difficult and it takes a lot of money to do that. And typically the work that I have done has been at the individual and sometimes at the family level or community level, but I've rarely done anything at the policy level. So thinking about the individual and the family level was pretty easy for us, and I've done a lot of diabetes self-management interventions with individuals and their support persons. But the policy level one we really had to think about. And I've used photo voice before. It's also called participatory photography, and they've used it all over the world to engage communities in issues in their community. So we thought that was a decent approach for us to use in this project, and hopefully activate participants to engage with their local grocers about better labeling the project. So that's kind of how we look at the literature, see what's been done, and then based on our experience, we put together this plan, and then we move forward and adjust as needed as we go on. So thank you. Another question, do each of the levels have to somehow work together to be chosen? I think the first two levels, we did, of course, plan them to work together. You know, families are so important in our communities that we definitely expected, you know, to have the individual with hypertension and a support person, family or friend, join to help support them and provide that autonomous support or autonomy support for them, so that hopefully, you know, things may change in people's households, and then maybe spread out to the community. The policy level doesn't necessarily have to work together, you know, directly with the other two levels. It can be something else. So far, we have them working together, but we could, you know, revise it if needed, to perhaps maybe do an environmental scan of what's available as far as food pantries, things like that in people's neighborhoods. So that one doesn't necessarily have to work together with the other two levels. Another question, what is the attendance like for the 8 class sessions? We experience a high dropout rate. So far, for our first class, these individuals were already an existing group and they were coming together every Friday anyway. So we had really good retention and attendance at those classes because they were already there. And but I know what you mean. I've done plenty of interventions where, you know, they're not existing groups, and it can be very difficult to get people to come to classes, you know, outside of their schedule. So that's why we're trying to capitalize more and more on existing groups. So working through churches, and working with community leaders that have a lot of influence and can, you know, encourage people to come to the classes. And, you know, we try to keep the number of classes to a minimum. There are 8 classes and they're weekly. But they do get to order groceries when they come to the class at the end of each class. So, you know, we provide incentives to try to get them too. Those are just some of our strategies. We have some more questions. What do you think the Photo Voice specifically brought to your study results? So we haven't used Photo Voice yet. We've only had the 1 cohort. I hope that through the Photo Voice activity, we can really improve people's critical thinking about their environment and their food environment, and to get them to notice, you know, what is and isn't available and labeled in their store, in the stores that they shop, and how to become advocates to change those things. So that's what I am hoping from the Photo Voice the project when we do it. Another question, do you need extra helpers in the Spokane cohort? Yes. Would you want to look into using nursing students? Yes, that would be fantastic. So we are trying to find a couple. I always, for most of my interventions, I hire and train people from the community. And especially, you know, in the groups where English is not going to be their first language. So we're working with the Marshallese community over there to identify a couple of people from the community who can recruit, and we'll train them to do the assessments, and then we'll have the peer educator deliver the intervention. But yes, we would look forward to having any extra helpers, especially because in this particular project, we're doing blood pressure, measuring blood pressure using the SFIG method instead of just the blood pressure monitors. So it's a more strict protocol, and we do need people with expertise in following research protocols, which can take quite a bit of training when you're training people that aren't familiar with that. So yes, thank you. Please join us. What data can you share about the project? So as I mentioned, we've only had the one cohort so far, but we haven't looked at any of the data because it was a small cohort, but people really like it. They like the education, they appreciate it. They appreciate the peer educator who's from their community, who can speak their language and translate things that aren't easily understood in English. And they appreciate the groceries. Everybody loves the groceries. And it's just $30 worth of groceries each week for 8 weeks. It's, you know, not a lot of money, especially if you have a big family. But we see it's an opportunity for people to try things that they may not have purchased before, or that they don't purchase in quantity. So, and in each of the classes, we do talk about the components of the DASH diet and encourage people in the intervention to try some of those things. Another, is the study still going on? Yes. As I mentioned, we've only had our first cohort, and our total number of people we need to enroll is 270, and so far we've only had 16. So we expect we will have multiple cohorts going on in different parts of the state, particularly in Western Washington, since the majority of NHPIs are in Western Washington and then over in Spokane. The photo voice, you know, there's lots of information online, and there are instructional booklets online about photo voice, and I encourage you to look them up. They have, you know, all the instructions on how to carry that out and what it's been used for. Talk more about the support person. What made you want to incorporate support person for your study? And what are their criteria? What would they baseline on it? So we just asked each of our participants to identify as a family or friend to enroll in the study with them. They just need to be 18 years of age or older, agree to be in the study, and we hope that they will attend the class that we have for them. But we don't require them to come to any of the other classes. We hope they will, but some people do come and some people don't. So it just depends. I find that in my interventions, married couples will come to the classes together, whether they're both enrolled or not. But often, if you have a parent enrolled in the study and one of their children, their adult children, is the support person, they have to work. They have children, so they have competing priorities and aren't able to attend all the classes. Terry, another question, am I familiar with Terry Shintani's your work? Yes, I used to work in Hawaii, yes, he did diet research with Native Hawaiians using traditional diet, and found many of the traditional items like poi were quite expensive. Yes, so we do encourage traditional foods as far as they are available here in Washington, and some may not be. So we try to encourage alternatives, healthy alternatives, and reduce some of the foods of the colonizers, and fast foods, and the packaged foods that are high in salt and sodium and things like that. So we try to encourage a realistic eating plan. Could you just go on? So someone asked if we can discuss the results of the first cohort. So we only had 16 people in the first cohort. So 8 were in the intervention and 8 were in the waitlist group, and they'll be receiving the education now or soon. I'm not sure if we said we could do data analysis before the end of the study. So I would have to ask our statistician if we can do that. Oftentimes, unless you say that you're going to do data analysis before the end of the study, that you can't, because you're not supposed to see the results before it's done, because that can influence changes in your intervention. So I'll find out though. Do we tell our participants what to buy for $30 and what not to buy? No, we do not instruct them to buy anything in particular or not to buy things, but the participants in the education, in the intervention, receive education at each of the 8 meetings focused on the happy or DASH eating plan. We provide them with a list of all the foods that are recommended in the happy eating plan. And so we don't tell them they have to buy any of those or not buy what they normally buy. We let them purchase whatever they would like, and we hope that they will purchase healthier options than non-healthy. Do you tell them to buy what they will eat during the week or buy for the family in general? No, we don't instruct them to buy anything for any particular time period or for their family. We leave that up to them. Although like I mentioned, we do hope that they are hearing us during the intervention and choosing healthier options. And with the first cohort, many of them did. Many bought lots more fruits and vegetables. They were buying nuts when we went over the nuts and seeds and beans project, but they still purchase white rice, bags of white rice and things like that. Grocery stores are difficult to work with regarding labeling. Yes, I agree, especially when they're large chain grocery stores. It's hard to change them. So we do have partners with the American Heart Association, and they have efforts going on to change some of the labeling of food items. What's the incentive for grocery stores to add additional labels than what's required? Right. So there probably is no incentive, and that's why we are engaging the participants to activate participants to engage with the grocery stores. And I think if you get a large enough group of community people together, that they can change things. They can work with grocery stores. And really for this study, it's mostly the local grocers, smaller individually owned grocery stores, not the big grocery store chains, because I think we really need the help of, and we see, the American Heart Association has gotten many food products to put labels on their products that say, heart healthy foods. So, we work at multiple levels to change things in grocery stores. Another question, the $30 that's used per week towards groceries, are the participants given a list? Yes, they are given the list, but not that will only cost $30. So we have a form they fill out, and it has each of the categories of the DASH diet and then other things that they just write in what they want. And our research coordinator purchases the foods each week at the end of the class, and for the waitlist group also. So they fill out the same form with whatever they want. And then our research coordinator, we purchase our foods through Walmart, through their website. And she then has to keep it to $30 for each participant, but we try to get some of everything they've put on their list. So they might say bananas, and so or rice or potatoes or broccoli or something like that. So we try to get everything on their list, but keep it to $30. And then the next week when they come back to the class, they pick up the groceries from the previous week. Because we also take their blood pressure each week too. Let's see. Yes, the grocery stores, the local grocers are part of the Photo Voice project. And we do have recipes to incorporate some of the foods into their diet and to decrease sodium levels, yes. We also, in the curriculum, we do education about food label reading, nutrition label reading, about measuring foods. We give participants, measuring cups at some of the meetings, and stress balls and other things like that. And as I mentioned, we do a lot of role playing, problem solving, and skill building in the classes, so that when people go to the grocery store, that they can read the food labels and identify foods that may be healthier for blood pressure control. And also with measurement of foods. Any other, let's see if there's any other hands raised here. Let's see, it looks like, so I just saw the home blood pressure monitoring isn't part of this study, but each week we do measure the blood pressure of the intervention and the waitlist control participants. So each week our peer educator is there, and our assessment staff as well, to collect blood pressure each week. We wanted to collect as many blood pressures as possible because there's a lot of variability in blood pressure. So it's better the more you have, the better. For this study, no, unfortunately, there won't be cohorts in Hawaii, but my colleague Kiave Koholukula is doing some studies over there focused on blood pressure. And manual blood pressure are using Dynamap. I'm not familiar with Dynamap, but yes, it is the manual blood pressure. So our assessment team is doing the blood pressure, because there are 2 other research projects associated with Native Chart. One is in Alaska, BP-ICANS is the acronym, and then the other one is in Oklahoma with American Indians, Chickasaw. And so we have a methods core who developed some standard methods that all of us use across the 3 studies. So we've standardized the way that we collect blood pressure. And we have a hypertension expert, Jason Humans, who trained our staff to collect blood pressure in the same way, and then they're all certified by him. And we have, on our surveys that we administer, several of the sections of the surveys are the same across all of the 3 studies. But then we also have survey items that are specific to our research projects, because they're all multi-level at 3 levels of intervention, but we're all carrying out our interventions in different ways. So the one in Alaska is in a healthcare system, and the one in Oklahoma is also community-based, but a little different than ours. So we are hoping for, yes, at least a 5-point drop in our in blood pressure. We are encouraging physical activity, but we're not engaging in physical activity with individuals. And I think that, we may do that if given the opportunity, but at least for this first group of people, they were retired and older, and many of them, there wasn't really a place to go walking where we were. It's just a kind of a shopping center and the office that we were in. So there weren't really a lot of opportunities, but we do devote one of our meetings to physical activity. And we are tracking blood pressure medications to see if there are changes during the intervention. And we'll see about the eating habits. And so I'm not sure if we'll reach our goal, but hopefully they will improve. My colleague, Kiave, did a hula intervention in Hawaii, and they have seen a significant drop in blood pressure in their participants, I think a 10-point drop. So we shall see. We have 5 minutes left, I'm told. From the previous response, it appears the food for $30 is not purchased directly by the participant. Studied nurse is selecting the food items. So the food items, so the participant writes down on a form the foods that they want. They don't necessarily write down a quantity of the foods. So they'll write bananas and, you know, maybe some salad dressings. Maybe they'll write down chips or something like that, or nuts. And we try to, as I mentioned, we try to get all of the foods, but we may not, for $30, be able to get big quantities of each of those food items. So we do try to purchase the foods that they write down, just not big quantities of them, to stick to the $30 per person per week. Anything else? Well, thank you so much. I really appreciate your time and attendance at this webinar, and we look forward to seeing you at our future webinars. Have a great day. Thank you.